well, good morning. Lieutenant Colonel Andrew Barr. I'm the Deputy Commander for Clinical Services over at the hospital, and appreciate y'all all being here. Hope everybody had a good holiday break. Basically what we're going to talk about today is protected health information and how that impacts commanders and first sergeants, and how the hospital and the medical team can assist you in getting the information that you need to better command your soldiers. This is kind of a panel discussion. I've got some experts down here sitting up in front that I'm going to introduce to you here in just a second. Certainly as we go through the slide deck, if anybody's got any questions, and you want to address those at that time, we can do that, or if you want to hold questions till the end, that's no big deal there either. So I'm just going to introduce our panel of experts over here from JAG. We have Major Calise. From Behavioral Health, we have Mr. Clark, and I think I saw Sergeant Flott as well. No, I did not. From the HIPAA, our HIPAA Safety Manager, Mrs. King, sitting up here in the front. From ASAP, Ms. Frederick, where is she? There she is. And from PAD, I think Sergeant First Class James is here. I didn't see Major Arrington. So anyway, this is kind of the team up at the hospital that either clinically or administratively helps manage protected health information. And so if we have any questions that I can't handle, the panel can do that, and certainly if they want to talk about anything in their lane, we'll let them do that as well. All right, so here's just an agenda for what we're going to be talking about today. Again, the main purpose of this, you're probably all tracking some of the things that we're going to talk about here: behavioral health issues, increase in suicide, frustrations that commanders and first sergeants have with the medical community having information that would certainly be beneficial to them commanding troops, but reasons why we can't give out certain types of information. And this came down from DA that we needed to kind of do a briefing and give you the reasons for some of the reasons that we do those things. Some of the things that we're going to talk about today are the types of health information that we can and can't give you, decreasing stigma, decreasing the reasons why patients don't come to us and what you can do to help them come to us, and then talk about increasing communication between the line and the medical services. All right, and then just a couple of rules here. You're going to see a lot today talking about behavioral health. That's kind of been in the news quite a bit over the last couple of years here. But really, protected health information and what we can and cannot give commands is covered in that medical information as well as behavioral health information. Okay, so the first slide we're going to show up here really focuses on behavioral health. And one of the main reasons this has become such a hot topic is because of the increase in suicide that we've seen in the military over the last couple of years. After the surge in Iraq, we started seeing a pretty steady increase in suicides, mainly in our Marine Corps and Army brethren, but certainly across all services. And what you'll notice is this graph over here. The civilian rate of suicide has been pretty steady in the United States of America at about 20 per 100,000. So for every 100,000 people in America, about 20 of them commit suicide annually. The reason that it's looked at per 100,000 instead of case by case is, fortunately for us, it's a pretty rare occurrence. In the military, over time, it's been even rarer than that. We've been around the 10 per 100,000 rate. So the military is about half of what you find in the civilian population. After the surge, though, we saw a pretty steady uptick, like I said earlier, especially in Marine Corps and in the Army, to where our rate of suicide over the last couple of years has approached and even surpassed that 20 per 100,000 mark. And so that's a doubling of the suicide rate in the military over the last couple of years, and certainly that's concerning to us as leaders and to the Army and the military in general. The reasons for that is the million-dollar question, and I still don't think that we have a great answer as to why that's occurred. We've postulated a lot of different reasons and have identified some commonalities amongst the suicide cases that we review, but there's really no one cause of suicide, and so it's kind of a multifactorial approach that we have to take to that. Before coming to Fort Leonard Wood, I actually served as the division surgeon for 1st Infantry Division at Fort Riley, and I've been a brigade surgeon before as well, deployed both times. And so coming from the line side of it, I certainly understand what commanders and first sergeants go through on the ground trying to command soldiers and the stresses of combat and being deployed and being away from family. One of the things when I was the division surgeon that we ran into in our year in Iraq back in 2010 is the issue of stigma. And between myself and my division psychiatrist, we rotated around the battlefield and talked to commanders and talked to soldiers about their outlook on behavioral health services and suicide and that kind of thing. What we found at a senior level, you know, E7 and above, 03 and above, is that there's no stigma out there. Senior officers, senior NCOs tend to be pretty good with the Army's program of encouraging behavioral health and encouraging soldiers to seek care. What we ended up finding, though, is that below that level, 03 and below some of our E6s, and especially down in the smaller units, you know, squad, platoon, even the company sometimes, there's still quite a bit of stigma out there. When someone comes forward and says, you know, I think I might need some help, or someone's a little bit different from other people in the unit, there tends to still be at that lower level hey, you know, why do you need help? You know, why are you weak? You know, you don't need to go seek that kind of help. And so that's something that we really need to get after and continue getting after in the Army at the small unit level, is breaking down stigma and encouraging people to go seek the care that they need so that it doesn't progress on to that snap decision, life-changing event, and suicide. And again, one of the big issues that we found is constant vigilance. It's basically getting into our soldiers' business. We're going to talk a little bit further here about the RED report. Has anybody heard of that? RED report came out in 2010 at a very senior level. Vice Chief of Staff of the Army directed an evaluation as to why suicide is happening in the Army. And two major things came out of that. One of them is due to the op tempo that we've had over the last 10 years, constantly deploying, redeploying, training, deploying, redeploying, training. We've kind of forgotten how to be a garrison army. We've forgotten how to do those garrison soldiering things that we need to do between just routine training, getting in our soldiers' business, knowing what's going on with them because we're so busy training up and getting ready for deployment. Knowing what's going on in your soldiers' lives, and that's not the company commander, you know, knowing what's going on in every private in the unit, but it's certainly at that lower leadership level, that squad leader, that team leader, knowing his 4, 5, 10 guys and knowing what's going on with them, knowing where they live, knowing where what their family situation's like, knowing what stressors are going on financially, spiritually, whatever. Knowing those kinds of things is protective for us. And that comes from forming relationships with our soldiers and maybe being a little bit different than we've been in the past. Not as much directive, but more kind of bringing people into the fold and really caring about them as human beings. That was one of the things that came out of that. The other thing is basically during the surge, of course, we increased recruiting quite a bit and brought a large amount of soldiers in, and there was concern that standards may have fallen and that we allowed a lot of folks in that may have had criminality in their past, behavioral health issues in their past, things that normally you would not get into the military with. And although that's in the report, I still cannot find any medical literature that proves that that's what's going on. So I think that's kind of anecdotal evidence that will get teased out with time, and we'll see as we drop 80,000 soldiers here in the next year or so if we kind of get back to this level of 10 per 100,000 and if that was part of the problem. Also just the op tempo in and of itself, the stressors that come from deploying, being separated from family and loved ones, financial difficulties that come up during deployment, the stress of combat, all of those things as we get back more towards a garrison army if those stressors decrease and we see less behavioral health issues. But unfortunately only time will tell. All right, so this is kind of a suicide case study, and you can kind of read through this as I'm talking. The point of this is not really to get into the particular case and kind of talk about what's going on with it, but it's basically to show you that suicidality is usually multifactorial. There's not just one thing that occurs. There's not one, hey, the 28-year-old specialist with 8 years in, separated from his family, that guy is going to commit suicide. It's not that easy. Every suicide is different, and certainly when we look back at all these suicides, we do see trends, and we're going to talk about some of those here in a minute, but unfortunately, there's just no one way that a case is going to present to you. So some of the things that will get pulled out in the slide here, relationship issues, problems, soldiers going through a divorce or soldiers being separated from a loved one for the first time. Financial difficulty is always a big one. When the soldier gets themselves into financial problems and just can't find any other way out, and the creditors are calling or UCMJ is occurring because of that. Behavioral health issues such as anxiety, the inability to adjust to stressful situations, what we call adjustment disorders, and then certainly depression can cause problems for us there. Being on multiple medications, and again, this is what we'll talk about a little bit later about what we know as a medical community and what you need to know to help you command your soldiers. The unit didn't know. we hear this a lot. You know, you have a soldier that, maybe a little bit of a loner, maybe not, getting in with the unit as well as possible, but we really didn't see much of anything coming. I guarantee you that someone somewhere knew something was going on. May it not have known the whole picture, but one and probably multiple people saw something that they were probably a little bit concerned about and may just not have acted to bring up the concern. And that's one of the things as leaders that we need to really stress with our junior leadership is, again, knowing your soldiers, knowing when there are changes in behavior, or knowing when we just have outright stressors that present themselves, we need to speak up. Probably the best way to do that, and again we'll talk about it a little bit later, is actually just addressing that with the soldier themselves. The best way for a soldier to come in and get treatment and get these things taken care of is for them to come to us of their own volition, rather than being ordered to do so or having a medical provider tell them to do that. So again, it is a big puzzle, and sometimes all the pieces are there and sometimes they aren't. Sometimes some of the pieces are missing, and again, it's trying to get all of those people that are involved in that soldier's life together to kind of put the puzzle together so that we can prevent suicide and have a strong force. Two of the patterns that we've seen downrange, especially with suicide and things to kind of keep an eye on inside the unit, there's two specific cases that we saw when we were downrange with 1ID. Older first-term soldiers, 28-year-olds with a family or without a family, kind of bouncing around jobs in their history, maybe a failure at certain things in life, and they a lot of times will come into the Army as a last-ditch effort. Hey, I can't seem to do anything else right, I'm going to come into the Army. If it's not what they thought it was, or they don't seem to fit in, or it doesn't live up to their expectations, sometimes that additional stress with other failures in life can cause them to snap and cause them to choose suicide. We had two cases of that in 1ID. One kid was 28 years old, kind of like the story says, had been in theater 3 days and went into a latrine with his M4. And again, nobody saw it coming. But when you kind of look back on it, there were bits and pieces that either medical community or command channels could see but didn't get it engaged. And again, the op tempo is what it is. You know, when you're in the process of getting a unit into theater and getting everybody where they need to be, sometimes folks slip through the cracks. That's why it's incredibly important at a junior leadership level for your junior leaders to know your soldiers very, very well. The other thing that we've seen teased out is senior NCOs and senior officers committing suicide. A lot of times is a loss of honor issue. So conduct unbecoming, financial difficulties, inappropriate relationships. When those things come to light, some of those senior NCOs or officers choose suicide over dealing with the problem. And so that's a common thread that we've seen as well. This is from the Red Report, and again, what I'm going to do is when we get the sign-in roster back, if you've put your email on there at the end of this, we've got one more briefing tomorrow. We'll end up sending out the slide deck to your email. It's kind of a good reference deck to have, and you can look at this a little bit further, but basically what this large maze is it just shows all of the different things that have been teased out from the suicides that we've had in the Army over the last year or so. I think this was 2010 when they looked at this. And so anywhere from looking at, down here, receiving outpatient behavioral health care, being on prescription medications, how many of them, of soldiers had inpatient care, criminal offenses with UCMJ, drug and alcohol offenses. And this basically looked at the entire Army and those populations. And then during that year, there were 160 suicides and 146 high-risk deaths. But of these folks, they had one or more of these issues identified. And it just kind of shows that soldiers can enter into the maze and they'll bounce around with behavioral health care, and then they might have some medications, they might have some UCMJ issues, and they bounce in and around the maze. And the thing that we don't want them to do is funnel into the middle where we show that they will commit suicide or have some other kind of a bad effect on them. What we want to do is engage them both through leadership and through behavioral health care and get them back out of the maze and into appropriate treatment so that we don't have any further deaths than we have. There's also on the back side of this a direct entry where we have risk-seeking behavior that is a more direct route into UCMJ offenses or suicide that is a little bit harder to get a hold of, but again, it's usually something that somebody's got some information on. Up in the top part here, just some of the known stressors, and we've talked about these quite a bit already, but it is amazing just the percentages in our force that have these issues that are floating around that could lead to problems if we don't engage them. So here's the balance that we have in the medical community with the line community. And we have our soldier here in the middle sitting on the seesaw, and what the commander's concerns are over here versus the medical concerns over here. The bottom line with all of this, and it applies to not only behavioral health but also medical care, if soldiers feel that their private health information is not private, they're not going to seek care, whether that has to do for a sprained knee, hemorrhoids, or for treatment of anxiety and depression. If they know that their commanders have full access to their medical records, which in the civilian world would absolutely never happen, an employer would never have access to what's going on between me and my physician, which is a protected relationship. Again, there are certain concerns that we have in the Army where commanders do have a right to know certain information from a mission perspective that private employers obviously don't have, and that's why there's this kind of strain between what we do in the military versus what we do in civilian life. So again, what we need to do in the medical community is get you the information that you need to command and to protect your mission and to protect your soldier, and no more information than that. And a little bit further on, we're going to talk more about that. When we swing more towards giving commanders more access to health information, that's when stigma and the hesitancy on our soldiers' part to seek care, that's when that goes up. So again, it's a trust issue that we have with them that they expect, and when we violate their trust by giving out too much health information and that comes back to get them, then they don't come seek care anymore, which can be a tragic thing. This slide just kind of talks about some of the silos of information that we all have. I'm a family physician myself, seen and treated patients my entire career. I will tell you that early on in my career as an Army physician, I was a complete and utter advocate for my patient, which is a good thing, but having spent no time in the line, not having spent any time in a regular company, I didn't really understand the dynamics that go on in the regular Army and saw my soldier only as a patient. And so what many of you have probably experienced is you get a young doc, captain, or major who writes you these profiles that make absolutely no sense at all, breathe at own pace and distance, and put things on there that, as you well know, there's no legal basis for you to follow that. And that's usually because the doc just doesn't know and is getting 100% of their information from their patient, the soldier. And so we have, in our information silo, we know what's going on with our soldier. We know about their behavioral health issues, PTSD and depression and anxiety. We know if they're being treated for alcohol abuse. We know what kind of medications they're on. And we have the information about them medically. Some of that commanders do need to know about. On the other side of it, though, commanders have the rest of the picture. Is the soldier undergoing UCMJ action? They may not tell the doctor that. Again, are they having financial difficulties that can be causing acting out or causing violations of UCMJ? We may not know about that. What's their home life like? Are the kids strung out on drugs and acting out in the high school, teen pregnancy, wife's about to leave you? Are there issues like that are going on? That would be very valuable information for the doctor to be able to help treat the patient. Do we have a loner in the unit, someone that's not coming on board and being part of the team? A lot of that kind of stuff we don't have access to in the medical community. So again, the issue here is how do we get this information flow back and forth, and unfortunately, or quite frankly, you can probably give us more information than we can give you. But again, it kind of helps build that total picture to protect the soldier. You should recognize this is the ARFR-GEN cycle, and this is basically just to touch on what we consider the medical safety net, mainly for behavioral health issues, but pretty much for all medical issues. As we enter into touch point 1, this is your pre-deployment health assessment. So when you have a unit that's deploying within 60 days of their LAD, the unit will come through the SRP, and then you fill out the PDHA form where we screen for medical issues, medications, behavioral health issues. And that's the first point in time where if we don't have good input from the hospital or from the unit, at least the SRP site can say, oh, hang on, we've identified someone here that we need to look into a little bit further, and they may not be deployable. You go through your deployment, and then usually within about 30 to 60 days of coming home, you'll do another assessment. Usually this is done by the command in relation with the combat stress team or with your organic medical providers. And this is a good touch point just to kind of finalize what's been going on during that deployment. Usually soldiers that have had issues when they're downrange, somebody in the chain of command knows about it. Our combat stress teams downrange are robust, and usually you don't have too much of an issue with getting your soldiers into the care that they need down there. And so what this touch point is great from a commander's perspective in being able to develop a plan for your soldier once they get back off of their deployment. It doesn't mean that they need to be met by a behavioral health professional as they're getting off the airplane, but you know, the squad leader, their NCOs that manage that soldier can say, hey, you know, I'm really kind of concerned about Bar. I think when we get back, you know, we should call him once a week, or you know, make a visit to the house, make sure everything's all right, you know, before he goes on block leave, make sure he's got our phone numbers and we're calling and touching base. And that's just good leadership. And that's kind of outside the medical realm, but again, that's what this touch point kind of gives us an ability to do that. Touch point 3, of course, is your reverse SRP, usually done within a week of getting back. Again, you go back through the SRP site. We have found that this is not real value add a lot of times, because most soldiers are not going to say, hey, you know what, I'm really having some issues, I don't want to go on block leave and I want to spend, you know, more time with my chain of command in the medical community. So a lot of times, even if soldiers are having trouble that we haven't identified earlier, we're not going to get the best fidelity of data during that, which led to the development of touch point 4, which is the reassessment, which we do in a 90 to 180 day window. This is actually critical. The honeymoon phase of getting home has kind of worn off. We've spent about 100 days back, and again, the newness of being back together is wearing off, and all of those issues that were there before or during deployment start welling back up again. Again, financial difficulties, relationship difficulties, inability to come together as a cohesive team inside the unit. And this is where we really get a big payoff from a redeployment cycle to get folks into care that they need. And of course, touch point number 5 just goes on annually. That's our periodic health assessment. It's a requirement for everyone in the Army to go in and see your unit PA or come to the hospital and be evaluated. It kind of takes the place of the old 5-year physical. It's much more streamlined, and again allows us to kind of deal with any medical or behavioral health issues that might come up. And again, it's a good point for the soldier to talk to the primary care manager or whoever's screening them and get the help that they need. All right, so the next few slides here, we're going to talk about command-directed mental health referrals. We're not going to get into too much detail about it, but just to kind of lay the process out for you, and then we're going to finish up with the types of information that we can transfer back and forth. I'm going to start in the middle here, and again, just to reiterate, the best way for soldiers to receive health care and behavioral health care is for them to come to us. Now, that doesn't mean that we just kind of let them go and hope that they receive care. There's a huge input here from the chain of command and from leadership. Again, if you notice something's going on with your soldier, change in behavior or something like that, the best thing to do is engage with that soldier. Hey, tell me what's going on. You know, I've noticed this change in your behavior. I've noticed this change in your ability to do your job. You know, what's going on? Hopefully that soldier has a relationship with someone in that unit that they feel that they can talk to. That is probably the best person to make recommendations to them and encourage them to seek care. When they come to us of their own volition, that's a decreased stigma environment. They haven't been ordered by the command to get that done, and they are come fully trusting and ready to receive care, and that's usually a very good relationship for us. At the bottom here, medically, certainly anytime we see a soldier in our clinics in primary care or pretty much anywhere in the hospital where we have concerns about their mental health or their physical health, they're possibly hurting themselves or hurting others, we can do a referral within the healthcare environment and get them over to behavioral health for evaluation. The command referral is the tricky issue, and again, there are very strict rules and regulations about how and when to refer a soldier over for a mental health evaluation. You can kind of read some of the areas up here that would lead you to do that. But again, this is something a lot of commanders will say, hey, well, I really think Bar needs to be in behavioral health care. I'm just going to command direct him, and that'll get him in there, and they'll start seeing him, and he'll be fine. Actually, the soldier just has to go to that one appointment to be evaluated, and the commander receives a formal write-up as to what's going on with that soldier. If that soldier doesn't want to, participate in behavioral health anymore, they may choose to do that. It's kind of like leading the horse to water. You can lead them there, but you can't make them drink, which is why, again, it's much better to have a collaborative environment with getting your soldiers into behavioral health care than it is ordering them to go do that. Okay, and again, this slide just kind of talks to what I've just been talking about. Therapy is a good thing. Behavioral health care is a good thing. We all receive therapy each and every day, whether you know it or not, whether it's talking to your spouse or a loved one, talking to a colleague at work. We have those ways to vent and talk about those things that are bothering us. For whatever reason, some people don't have that or don't seek that or need more than that. And again, that's where getting into a formalized behavioral health environment is a good thing. This area in the middle here, I do want to talk to, this is some of the information that we owe you as commanders and first sergeants. I always recommend to company commanders, we have formation in the morning, hey, fall out for sick call. The first step back to the unit from a hospital appointment should be right back to that first sergeant with a profile in hand. That profile should either say return to duty or come to you with whatever duty limitations you have. And that's probably the best way that company commanders and first sergeants have to track kind of what's going on with their soldiers. What we are going to talk to you about, information that you can ask for. We can always kind of give you the general health status of your soldier. We can tell you if they've been to the hospital that day for an appointment, if you have concerns about your soldiers, going to sick call, 2-3 times a week. It is well within your right to call over and say, hey, my guy's missing a whole bunch of time. Is he showing up? And we can tell you yes or no. We're not going to tell you where they've been, though, because, again, that would be a violation of their protected health information. Again, we can tell you if they've kept appointments and then certainly the profiles that they're on. And I would ask you, being the senior clinician over at the hospital, if you're seeing profiles that don't make sense to you, you need to let me know, okay? And I'm sure you've all seen some that don't make sense to you. The profile form is a medical recommendation to a commander on what the provider feels the commander needs to do to help protect their soldiers' health. Things like no field duty or no running no PT with unit, stuff like that. That's not really within a doctor's purview to make those recommendations to you. There may be very specific things, no running in formation. Okay, well, if not being able to stride out causes the knee pain to get worse, then yeah, we don't want you running in formation. So we have to kind of keep some common sense to this. And if you as company commanders and first sergeants or commanders at all level, are seeing things that don't make sense to you, I'd appreciate knowing about that, because that's training that we need to do on the medical side to get our docs smarter on how to write profiles for you. All right. So communication that occurs between a soldier and their behavioral health provider is protected. Yes, there is a ton of juicy information in there that if the commander had that, they would probably be able to react certain ways to help affect positively what's going on in their soldier's life. But again, as soon as we do that, we increase stigma and that soldier doesn't come back to see us again. So the vast majority of what goes on inside the medical record stays in the medical record. These areas up here just kind of outline the things that we do need to tell you about. If we have concerns about a soldier harming themselves or harming others, that's something that a commander has a right to know. If there's a harm to the mission, meaning if we deploy this soldier, if we put this soldier behind the wheel of a heavy vehicle, if we allow this soldier to handle a weapon or ammunition, that there's danger in that to themselves or to the unit, we owe you that information. Certainly, sensitive mission responsibility. So if you're dealing in an information environment where, because of medication or behavior, there might be a breach to that information and therefore a negative impact on the mission, we owe that to you as well. Certainly, if your soldiers are hospitalized, we let you know about that. And if they are in substance abuse treatment, we can let you know about that as well. Let's see here. So again, this slide is just kind of a roll-up of what was already on there. So I'll let you kind of read through that, and you probably already have. But these would be the situations that you would consider sending a soldier over against their will for a command-directed mental health evaluation. Okay. Without getting into the legalities and how exactly you do that, and Major Calise can either speak to that or let you know where to go to put that process in motion. What happens is you identify and execute the proper mechanisms to get that soldier over to us for that command-directed mental health evaluation. The behavioral health provider will end up seeing that soldier and doing a full evaluation on them. and then we'll submit written feedback back to the commander on what's going on with that soldier, and then make recommendations for future care to help address that soldier's issues. This is kind of a busy slide. Again, when I send these out to you, you can look through here, and again, guided by regulation, and this is just kind of a wire diagram of what happens when you send a soldier over to us for a CDMHE. Okay. So again, when those situations that were on the other slide present themselves, again, the thing that we're all concerned about is protecting your soldier from himself. And so probably a good idea, although not required, if you've got someone in that situation, to provide them an escort, someone obviously that outranks them, NCO in their chain, or that kind of thing. They have to have, by UCMJ, by guidance, they have to have an explanation to them as to why this is occurring and what they can expect, and then you know, what issues they had that led you to refer them over for care. Again, I'll let Mr. Clark speak to this, but typically we have 2 days to get that information back to you. Mr. Clark, I think within 24 hours is usually the norm over at the hospital. Obviously, you know, if you've got a situation requiring emergency, you know, care, we're going to get that information back to you as soon as possible. Also during this, again, having gone through this with a soldier in my command earlier in my career, the last thing you want to do is prohibit them from talking to you know, trial defense, from their congressman, from the IG. If you put yourself in the middle of that process, that they actually have a right to engage, that's going to get you into trouble as a commander. Okay. The things that you're going to receive back in the response from behavioral health basically talks about the soldier's diagnosis, you know, what we've found, what their prognosis for treatment is, you know, whether we think that, you know, with X, Y, and Z treatments that we're going to get them better over a certain period of time, or if this is something that's going to lead to chapter. Again, you're going to get a recommended treatment plan, whether that's medication, you know, further psychotherapy, other treatments that might be available, and then again their suitability for continued service, whether we think this is going to lead to separation from the military, or whether we can salvage the soldier. Certainly, depending on what comes out of that, you know, you might need to move the soldier into the barracks, depending on what their living situation is, depending on if the issues that we've identified have to do with their family or their home life. Obviously, avoiding the use of alcohol. We're going to make recommendations whether they can or can't handle firearms, and then certainly if they've threatened harm towards others, you know, making recommendations for keeping them away from the potential victims. Okay. Key part of this slide is once you get that communication back to you with what's going on with your soldier, you should discuss that case with the behavioral health provider and ensure that you're comfortable with the recommendations. And if you don't understand the recommendations or the diagnoses that are in there, ensure that you talk with the healthcare provider about that. If you concur with those recommendations, then, you know, directing that soldier into that treatment program is certainly the appropriate solution there. If you don't concur with those recommendations, then you can provide written notification to your commander with the reasons that you don't concur with what we found, and then that notification will get submitted to the MTF commander, which is Colonel Eggleston over at the hospital, for further adjudication. All right, these are last couple of slides here just talk about what we can and can't do. And again, that handout that you've got there, there's a lot of great information on that, and the next couple of slides is basically just a summary of some of the things that are on there. But again, I'm just going to kind of go over these with you real quick, and then we'll take any questions or comments that you have. Again, we've kind of talked about today why we have to limit the amount of protected health information that gets back out to commands. Again, communication being very, very important here, not communicating through sick call slips. Again, if you have concerns about what's going on with your soldier from a medical perspective, I would highly encourage you to contact me, and I can get you into contact with the right provider over at the hospital where the commander and the provider can kind of talk about the soldier's situation a little bit more and get that profile squared away and get that soldier the continued care that they need. We can't, again, talk to you about why your soldiers are coming over to the hospital, but we can certainly let you know that they've been there. I'm sorry. Yeah, and a lot of the reason for the information that comes back and forth has to do with the impact on the mission. So when you're concerned about what kind of information you can have, always ask, hey, how does this affect the mission? And if there's really no clear-cut definition that the information you're seeking impacts the mission that you've got the soldier on, then that's probably going to get denied to you from the provider that you're asking it for. Again, the last bullet here, we've already talked about many of the reasons that we would give you information on a soldier. A lot of those have to do, again, with harm to self and others or harm to the mission. There we go. If we've got soldiers that are in substance abuse treatment or in inpatient care hospitalization, again, we're going to talk to you about that. We're certainly going to give you information on missed appointments. As you're probably already aware, that roll-up comes out from the hospital back to the senior mission commanders monthly, and you may or may not be getting dinged on that. We've actually done a phenomenal job with the help of our chains of command here on Fort Leonard Wood to take no-show rates from the 10 to 15% rate down to about 5 to 6%. So you guys are doing a great job with that. Certainly the whole MEB, PEB, IDIS process, when you have a soldier that's not fit for duty anymore and is going to go through the medical evaluation board, between us and the PEBLO, which is the liaison officer for the soldiers board, we owe you information on where your soldier is in that process and what the next steps are, so you'll get that as well. And again, acute medical conditions that are going to affect the mission, we've already talked about that. And then certainly you're going to get the results of the command-directed mental health evaluations that we've talked about. Once you have protected health information, that information that we can give you, you are then an agent of HIPAA and of PHI, of protected health information. So the information that we give you has to be locked up and held tight. You can't go discussing that with other members of the command, and really rely on you to, again, help protect that sensitive information so that it doesn't get out and, again, cause more stigma. All right, this was just, I just ended up putting up a couple slides here. This was the old form. The form that you have now is the one that's been updated by Ms. King and has our specific information for the hospital. I will put out there that if you can get to our SharePoint, if you'll just Google GLWACH, G-L-W-A-C-H, SharePoint, or do a search for General Leonard Wood Army Medical Center or Community Hospital, you can get to that page. And right up at the top on the left is a HIPAA and security information link. If you just link there, that'll take you to a page that at the bottom has information on HIPAA that commanders need to know. It's a great, robust site. It's got about 6 or 7 documents on there that you can read through that'll help provide you guidance on what we can and can't give you and how to get the information you need to help your soldiers.